Thank you so much again, Secretary Becerra and Joanne. That was fabulous moderation, and we'll get more here in a minute. I'm Alex Trianis. I'm the Dean of the Carey Business School here at Johns Hopkins, and it's a delight to have you all here and looking forward to the panel as we dive even deeper into the warming waters here. I want to thank, first of all, Dan Polsky, who leads our Hopkins Business of Health initiative that I know all of you are familiar with. Dan has done a fabulous job at really bringing together all the interests related to business of health at Hopkins. This is a wonderful collaborative effort of the Carey Business School together with the 3 schools at East Baltimore, the School of Medicine, Bloomberg School of Public Health, and the School of Nursing. And when we talk about the business of health, we're not just talking about ROI and margins and profitability. We really are talking holistically about the intersection of business and health. A lot of that in the health sector, but even beyond the health sector. And I think today's theme is really indicative of how deep the issues are, that we care not only about customers, about the patients, but also about our employees and also about our communities as well. So it's really fabulous that we're able on Earth Day to focus deep into this issue. So with that, I'd like to introduce Joanne back, although I think she may have temporarily left. But while I do that, let me also introduce our 3 panelists that are going to dig deeper into the issues that were introduced a few minutes ago. And I believe that we are going to need, I don't think you're going to share these 2 chairs here. So we will be coming, we'll be bringing up a couple more chairs, I believe. But let me go ahead and do the introductions. So we have Deanna Benner, who is a women's health nurse practitioner at ChristianaCare in Delaware. Deanna is also, importantly for this panel, is also co-chair of ChristianaCare's Environmental Sustainability Caregiver Committee. We have Dr. Jeremy Greene, who is the William H. Welch Professor of Medicine and History of Medicine at Johns Hopkins. Jeremy is also director of the Institute of the History of Medicine and director of the Center for Medical Humanities and Social Medicine at Hopkins. And Dr. Jodi Sherman, who is Associate Professor of Anesthesiology and Epidemiology at the Yale School of Medicine. She is also Medical Director of Sustainability at the Center for Sustainable Healthcare and Director of the Program on Healthcare Environmental Sustainability at the Yale Center on Climate Change and Health. So as you can tell from those introductions, we have 3 individuals who are already deeply thinking about the issues that were introduced earlier, and we look forward to their discussion. And again, Joanne, thank you so much for moderating this panel, and we look forward to an engaging conversation. Thank you.
I wanted to add just a few tiny additional notes to the bios. Jeremy is working on a book about medical waste. It is called, the working title at least, is called Syringe Ties. That hasn't changed, has it? And it does have a Jersey Shore angle.
It does have a Jersey Shore angle.
And Jodi, I also wanted to mention, in addition to the work she's doing at Yale that you're going to hear about, she serves on the National Academy of Medicine's Collaborative for Decarbonization of the U.S. health sector. So she is really plugged in on a sort of the nexus of where an awful lot of things are happening or trying to happen. And when Deanna talks about caregivers at ChristianaCare, she means the doctors and nurses. She doesn't need the daughter-in-law. So she's working, and I really, really wanted a nurse on this panel because nurses are really doing, in health sectors, health systems I have visited, nurses are really doing a lot of the work on the ground. They have a lot of control over what's used and what's, in some cases, what's bought, and how to throw out less stuff.
Thank you for including nurses.
Yes. No, I mean, and student nurses too. I mean, medical students and residents, a lot of things are bubbling up from the generation like my kids who are very concerned about, are they going to have a planet? Yeah. But on the ground in a health system, a lot of the work is from nurses. when Dan and I started talking about this many months ago, at first I think he thought it was just something, I mean, he respected, he was glad I was so enthusiastic, but I think, you know, he and my colleagues at HBHI really began to understand this is a health issue. It's also a business issue because healthcare is 18% of our GDP, something like that, around 1/5. The amount of waste, as we've heard, is extraordinary. So much of what you use is thrown out. And I actually wanted to start, it's changing, it may be getting better, but Jeremy, you also work in a clinic one day a week in Baltimore, a federally qualified health clinic for low-income people. Jodi, you're an anesthesiologist. You're a women's health nurse, so you're working in an ER situation a lot. I wanted just each of you think of just something in your clinical life, in your clinical lives, of just sort of recently where you just like sort of stopped and thought, am I really throwing all this out? I mean, give me an example, because not everybody here is a clinician, of stuff that we might be like scissors, you know, that you actually throw out. You want to start?
Scissors is one of them. I mean,
even if they only cut gauze, right?
Well, no, we have these suture removal kits, and it's fascinating. Although what I wanted to start with, though, is the speculum, right? So
and then he's going to give us some history, but let's just start quickly with because I want people seeing on a C-SPAN and people in the audience to understand really everything you touch gets thrown out.
Yeah, well, you know, I haven't been in medical practice that long, right? I'm an internist. I work at a community health center. The pelvic exam is an important part of community health, and the physical substance of what we use, right? When I was in training, we used metal speculum, which were reusable, right? Sometimes would be cold, sometimes would be warm, depending on who was actually using them. The plastic speculum, once introduced, you know, was more reliably warmer, right? And would still have a reusable light source. And it's only in the past 5 years that my clinic has shifted over to using a plastic speculum that now has a disposable light source. So that now, in addition to all the extra plastic we're putting into the waste stream every time we do a pelvic exam, there's you know, rare earth metals, there's these battery sources and LEDs that are being thrown out. And that was part of what woke me up to realizing that actually all of the objects in my clinic were moving towards increasing disposability, and the moment in which most of the rest of the sectors were actually trying to grapple more concretely with sustainability. So we just keep on producing more and new kinds of costly trash. And the speculum is a good example of that.
Oh, I could talk, you stole mine. I could talk about vaginal speculums all day. In our hospital system, in order to pass a Joint Commission's inspection, we were using metal speculums. But I guess there was a little bit of a problem that came up with just the cleansing. And as somebody said, you know, it's like it's washing your dishes off before they go into the dishwasher, like cleaning the speculums off before they go into the enclave. So instead of, you know, what would be the cost-effective way of re-educating the caregivers of how to properly wash off the speculums before they put them in the autoclaver, the whole health system had to switch over to plastic vaginal speculums. Yeah. And once you go there, there's no coming back from there. So, but my thing is disposable pillows. And
disposable pillows?
Disposable pillows. So there was somebody that did a project that showed that we could save the health system money if we changed from reusable to disposable pillows. And it was something about like $10,000 a year. But what they didn't take into consideration is that disposable pillows are vacuum sealed. So they come like this big, and they come in so much plastic. And the staff hated them, the patients hated them. The nurses were putting 6 disposable pillows per bed for a labor woman to compensate, to maybe get to a pillow that might be this big. And the battle to change back to reusable, which I recently just won, took so long because, you know, hospitals, there's so many different meetings. So what was a good intention at first was never really thought out. But our labor ladies now do have fluffier, more reusable pillows that are great for the environment.
Jodi.
It's really challenging to pick one item. I mean, things from low-risk devices like linens, not just pillows, but the bed linens as well. Blood pressure cuffs, pulse oximetry probes, so things that are low risk in terms of infection transmission, all the way to things that are complex surgical equipment that cost hundreds, if not more than $1,000 each, have become single-use disposable. And yet we reuse thousands of things every single day in the hospital, including thousands of surgical instruments. So just because something needs to be sterilized or sterile does not mean it needs to be disposable. And in fact, we can transmit infections with a single-use disposable device just as readily as we can with a reusable device. So we really need to dispel this notion that single-use disposable is better for patient safety. Now, for things that are difficult to clean and high risk, things like needles, tubing, things that are cheap, that are very difficult to clean, of course, we're not going to reuse those things. But something that we use every day in my profession as an anesthesiologist, a laryngoscope, a device that we put into the mouth to safely put in a breathing tube while patients are under anesthesia to control their breathing. This has become disposable as well. Meanwhile, we can go to restaurants and use reusable silverware, tableware without any issue. So why do we think that something that goes in the mouth needs to be single-use disposable?
Right, okay, so that's one of the big myths, and we're gonna come back to that, which is that we have to throw things, it has to be single-use, or else we're gonna kill everybody, right? And that is not true, and that'll come up. I want to just turn to Jeremy for a minute now, or a couple of minutes now, because he is a historian, and he can help explain how we got to this point, because, I mean, plastic didn't even exist when medicine began. How did we get to this sort of disposable culture, and what do you know, and what does the history tell us about the future? Yeah,
well, thanks for that. And actually, this comment really reflects on both of your recent comments, right? Like, in terms of how do you switch back, right? And how difficult it is to switch back. And how do we take these assumptions that are built in that we need to valorize disposable, that it would be irresponsible for healthcare to use things that are not single use. And so if you go back 60 years though, right, you see a healthcare economy in which the construction of medical devices were all built to be durable, precision instruments meant to be reused and last. And that was a value structure that was built into how engineers worked, how industry actually predicted their markets. And if you look at the transition that happened as disposables really start entering healthcare, like a trickle in the 50s, a huge wave in the 1960s, you know, journals for hospital administrators and purchasers are all fretting about the problem of how difficult it is to switch over to disposables. So it's the same kind of problem that you're dealing with, Deanna, in reverse, in which it was a tremendous amount of work to make healthcare single use. It wasn't cheaper, right? So disposables were actually initially more expensive. They weren't clearly safer, right? So there's all of these processes that happen in the transformation which were the result of human decisions. And ultimately, they made sense, and I can pinpoint a year, it seems about 1965, when it finally became cost-effective to use plastic single-use syringes, right? But until that point, there were other reasons besides economics that actually drove that transition. And then once that behavior had changed, actually the economics matched up as well. So I think this reflects back on one of Secretary Becerra's comments that actually, you know, if we actually drive a set of value choices, that can actually then drive markets in the right direction. And that there's nothing inevitable about the use of disposable objects. Yeah.
Okay, so that, well, but except that it's really good business to, I mean, if you're making things that are used only once, I mean, people have to keep buying them. So it's not just we'll talk about how you changed the market in a minute, but I mean, the market did, their point is the market changed once, and we can, in fact, have some hope that we can change it again.
Yeah, I agree. I mean, my point here is that we shouldn't accept the objects of our everyday life and the things that we assume from sort of a hard-nosed pragmatic sense need to be the way they are as being fixed things in our world, right? Even the statement that disposables are cheaper, right, wasn't initially true, right? It is the result of human markets.
So we switched to garbage even though it costs more.
Exactly. It did other
American
things.
healthcare.
So, right, so if I may respond to that. So in the case of syringes, we're not going to go back to glass. It doesn't make sense. But I will say that by and large, for every single, this may not go across the spectrum, but for every single device I've looked at, that there was a reusable and a disposable option. If you do the internal cost analytics, everything I've looked at has actually favored reusables. So it is a myth to think that single-use disposables are cheaper. And you have to be very careful who does the analytics and how you do it. It has to be across the entire organization, not just a silo, not just a central sterilization supply department, not just the procurement department. You have to figure in how many uses and also the cost of refurbishment, of cleaning, all that has to factor in. And by and large, reusables do tend to be cheaper. But the challenge culturally of switching back now is that if you've lost the infrastructure, the staff, the setup to be able to handle those devices, then it becomes a huge change management issue. And it just becomes too much for leaders who are really pressed with multiple crises, particularly now coming out of the pandemic. Even with the financial crises, when there are clearly going to be financial wins here, to be able to even divert some staff to be able to start the change management process becomes too much to even consider.
So talk a little bit about, I mean, you're both a national expert on this, but you're also a change agent at your own university, your own health system at Yale. So talk about how you were beginning to get people to buy in.
Well, you have to get all the right stakeholders in the room, right? So, you know, that in the case of medical devices, you have to work with the value analytics team. It's very challenging because everything you purchase is bundled with other things that you purchase and have contracts. And so to take one device, even if there's a clear win, and try and switch it back to reusables. You have to look at how long the contract is, how much you're contracted to buy, how it's tied with other products. So then it becomes this complex issue for the value analytics team just to investigate what it's going to take to unwind those contracts. And then you have to get the buy-in from all the clinical staff that it really is okay to use these reusable devices. And, you know, so it is really a challenge to move back.
And I know, I don't want to get the whole panel on the anesthetic gases, partly because I can't pronounce them right, but talk briefly about, I mean, because two of the most common gases are actually really bad for the earth, and there are cheaper, safe, equally safe, and actually cheaper alternative anesthetic agents that have been endorsed by the professional society, the American Association of Anesthesiology. I might not have the exact acronym right. Has Yale switched over, or is it a little here and a little there? You know, more than one building they do. I mean,
right. So just to explain a bit more, if people aren't aware, so all inhaled anesthetic gases that we use for general anesthesia are potent greenhouse gases. Your body doesn't really transform them, so your body takes them, they do their thing, and then they are exhaled, and all the gases just blown off the hospital rooftop.
And they live there for years in the environment. Right?
They do. They live there anywhere from a few years to over 100 years, depending on the type of gas. So all inhaled anesthetics are potent greenhouse gases. We do have, in some instances, alternatives. There are IV anesthetics. Sometimes anesthesia can be done with what's called regional anesthesia, where you just numb up a body part and then just give some light sedation. So they're not essential for all procedures, but by and large, it is the most predominant method of providing general anesthesia. And of the four main gases, two are much more potent than the others by thousands of times compared to carbon dioxide as the equivalent measure. And the other two gases are much lower in potencies. So one of the most expensive gases is also the worst for the environment. That's dust rain. I'm proud to say that Yale New Haven Health System got rid of this gas in 2013. We're the first to do so in the world on environmental grounds based on our life cycle assessment research. And this has started a wave globally. It has now been banned in Scotland. It's being removed from England this year. And there's movement to ban it in Europe by 2026.
And how common in the U.S. is that switchover?
We don't have data on that. I can just tell you anecdotally that it is becoming more common, and by and large, because it's much more expensive. We saved $1.2 million just in our flagship hospital 11 years ago by getting rid of this. The other challenging gas is nitrous oxide. It's a different type of gas, and it's piped through the hospital walls. And a lot of gas is lost at the connections between
like 80%, up to 80%.
Well, actually more than 90%. Oh, okay. And so just simply getting away from the pipes and going to portable tanks at the point of use, you can eliminate 95% of that.
Right. Okay. And let's go to Deanna. Because in your institution, you were sort of the change agent, you and a small group of colleagues, and you're exactly the example of the nurse I was talking about. Yeah. I didn't know her when I was writing about this. I just met her on the phone this week. But it's the classic, you are really, people like you are really how a lot of change is beginning in healthcare systems. So talk, and you're not as far along as Yale, and you're not as far along as, the UC system where it is mandated. But like, how did you start, and how, just tell your story, because it's an interesting story.
I'm definitely a bottom-up change agent. And the reason why I'm here today is because my teenage daughter has eco-anxiety. And for those of you that don't know what eco-anxiety is that these young adults, they know that climate change is happening and that it's destroying life and species, and there are things that we can be doing now, but they don't see adults doing those things. So they carry the burden of saving the world on their own shoulders, which is a lot of work for these young adults. So to help my daughter, I vowed to model to her that adults are fixing the problem right now. So the first thing I had to do was learn about environmentalism and climate change, and I was so shocked about how much the healthcare industry that I've been in the last 25 years contributes to climate change, but how we can also be the solution. So I started to make, once I had this knowledge, I started to make PowerPoints about it, thinking I would just go to hospital leadership, they would hear this, and like everything would change. So I realized, though, I was just one nurse practitioner and one PowerPoint, and I really wasn't making the change. So I really dived in, and I really have followed Dr. Sherman's work, and I made my PowerPoints better, and then I decided I was going to try and get in front of any group I could at the hospital to share this information, because I wanted to turn that climate volume up in the hospital system so that everybody would hear it and then change would happen. So when my hospital system, which we did sign the HHS pledge, which is so great, and we have a environmental social governance leadership structure, and part of that structure was the Environmental Sustainability Caregiver Committee. So I was asked to lead it, and then once I had that committee, I've just been running with it. The first thing I did was I scheduled meetings with like key players. So I wanted to talk to the lead of infection prevention, and then I went to talk to the lead of zero harm, and they all got my PowerPoint, which basically was like Dr. Sherman 2.0 of all of how we pay so much for healthcare in this country, and that we actually don't see the healthcare results. So there's a lot of opportunity to decrease that low-value care without sacrificing on quality. So I made all these strategic meetings, but at the same time, I'm trying to engage caregivers, because my main goal with all of this is to make healthcare the solution for the larger greenhouse gas problem. And you really have to engage the caregivers, and that's the problem, because our hospitals and all of our wonderful people that work in the hospitals, they're from the community. They've been exposed to what the fossil fuels have injected the disinformation campaign for decades. So even though I tell them that this is a really important issue, I can see it's not really making the change. So I just had a conference last week that was the first conference at our hospitals, and my health system supported it, and it was a climate and health conference just to educate caregivers about this issue, so there can be more engagement to help with our hospital system and decarbonization, but with the larger portion of larger purpose of going out into the community and telling people about how climate and health is connected, and how we have to work together on this issue.
So Jeremy, as a historian, how are we going to look, or how is the next generation going to look back at 2024? Well, in terms of health.
Again, so historians aren't as good at futures.
Yeah, but I just put you on the spot.
But my hope would be, and this is the way I'm increasingly saying,
as a clinician, how are we going to look back?
You take it just as a me and all of the things I might bring with me, right? But I'm very inspired by Deanna's story, right? And I actually think that this kind of thing is happening all over the place, right? Like when we've just the Sustainability Leadership Council has existed at Johns Hopkins for a while now. Last year was the first year that we actually put a healthcare section in the annual meeting, and then this year there was a full day's worth of events based on healthcare practitioners, health policy researchers, people coming up from different parts of the healthcare sector who are all really waking up to this issue right now and wanting to do something about it. So I think it's not just us here on this stage. I think there's a tremendous amount of momentum building in this sector. And I think that it is a bottom-up thing, right? I also think it's something that's happening as all of us learn to question the calculus on which the the bargain for valorizing disposability was made, right? It's not enough to merely decarbonize healthcare, right? We also need to look at the physical substrate of what we actually put out, why we use so much plastic. And again, I agree with Jodi's point that the disposable syringe is unlikely to shift back to a glass syringe. Disposable gloves are unlikely to shift back to reusable gloves. I mean, I could show you ads for glove washers, dryers, and powderers from 1961. I don't see an economy for a market for those products, right? But something like drapes, right? You look at this literature on surgical drapes, and I think part of the reason it's so wonderful to engage with anesthesiology in this space is in addition to the gases, right? The OR is the largest site of waste production in the hospital. All the stuff that's left on the floor. And when I was in my medical training, I did 2 different surgical rotations in the 90s. One was at the Brigham and Women's Hospital, but one was at the Mass General Hospital. At that time, the Brigham was using all disposable drapes. Mass General was using all reusable drapes. There was no evidence that one was safer or even more cost-effective than the other. It was just a different style space. But as we move towards, using all disposable drapes, right? That's a reckoning that no one has really taken like a close enough look at. So I actually think that what's happening in 2024 is we revisit these calculations. Not every item can go back away from single use, but a lot of them can, and we need to be asking these questions more clearly. The last thing I'd put on top of, Jodi made a point which is crucial, which is why did we shift away, and what capacity did we lose in that shift, and what does it take to rebuild that? In the 60s and the 70s, it was explicitly shifting away from labor problems to supply problems. Labor was seen, the skilled labor required to run the sterilization facilities was seen as an unpredictable thing for hospital managers. Hospital managers saw themselves gaining a benefit by turning into a supply chain problem. And as long as we could still further and further globalize that supply chain and have that access to these goods, it worked for those who marketed the goods as well, right? So what happened in the pandemic, though, is, of course, we all recognized that dependence on these global supply chains was an incredible liability. And the question is how long we can keep open what we learned at that point, right? There was a window of learning that happened of our dependency and the investment in individual capacity and skilled labor being something healthcare institutions really should make, which I hope that actually we can extend to this point. So 2024 for me is a year of reckoning, recalculating, re-examining this shift from labor to supply, thinking about the cons as well as the pros, and then rebalancing the tables.
In the health systems that are engaged in this effort to decarbonize, and on different levels and different, there's a lot of activity. And it's both, some of it's top down, a lot of it is bottom up. I mean, what Deanna's doing is I didn't meet all of them, but I would hear stories about, a student nurse coming in and saying, one example was, like you said, all this material that's thrown out in the OR, and this, I can't remember which California school it was, I think it was UCLA, where one of the student nurses, piped up and said, well, once the patient comes in, all this plastic, we can't recycle it if there's any exposure to bodily fluids or drugs or anything. So why don't we just keep the patient out there for like 30 seconds longer and let's take out the plastic, everything we unwrapped, let's get the plastic out of there. And if you think a health system the size of UCLA, that's a lot of plastic from something really, really simple. So little things add up, things like we're not gonna go back to glass syringes, but Providence is a health system that's been doing sustainability work for literally decades. They're way ahead. Those sharp containers in every, you see them all over a hospital, every clinic. They used to be, Providence, they were single use. They'd fill them up and they'd throw them out, and now they're used, I think 60 times each, so that across that health system, that's just, truckloads of plastic that's not getting thrown out. So how much of this are these little steps going to add? There are a lot of little steps, and they're exciting and they're easy to replicate. But do the little steps add up to matter, or do they become window dressing, even if they weren't intended to be window dressing? They were intended to be the beginning of change. Do any of you? I'm having a disposable waste problem here with my pen. Where are we with all this in this sort of early adapter systems, there's stuff, there's activity, there's ideas, but does it add up to much yet?
I mean, I think there's low-hanging fruit and there's the big structural changes. And if you're asking, should we be moving past the low-hanging fruit into the structural, my answer would be right? I think it's like a question of Greene inhalers, for example. Like one of the things we understand is there's been a lot of attention, every time you use an inhaler, as someone who lives with asthma, this is something I do myself, when you use an aerosolized inhaler, it emits directly, some CO2 into the atmosphere. Now that amount is nothing compared to what is coming out of the OR, right? And so you might say, well, that's an easy thing to gain a symbolic win on, right? But what really matters is what's happening elsewhere. But I would say it's an and. It's actually something that helps to propel the visibility of the need for further change.
I think all the little things do matter, because if you have my organization, we have 14,000 employees. So if everybody's doing their part, I think you can have huge change. Like one thing in our emergency department is we realized we were putting gowns on all of the stretchers before the patient went into the room. Well, most people don't actually need a gown. So all of the energy to wash and to produce that gown goes into the waste. One thing that we're doing at the hospital is when I took over the committee and I engaged caregivers, the two things they cared about was changing from styrofoam to another alternative that was safer for patient cups, and also recycling. So recycling doesn't really affect greenhouse gases, but caregivers, it's a very visual thing that people are concerned about. So I went to the recycling facility and I learned what we recycled. And I learned we were recycling incorrectly, sheerly for the fact that we were sending the bags of our recycling to the facility. And the bags were then just being thrown in the trash. So a very expensive way and a long way to get to the landfill. But the one thing I really learned about in that tour is when they were shipping the trucks off with the material that was actually recycled, I said, where is it going? And they're like, oh, it's going overseas. So I realized that even when we do recycle perfectly, it's not the best option. So then we came home, back to our hospital system, and we said, how do we reduce waste further? So we started a medical supply donation program where instead of trashing all of our extra supplies, we're now collecting them. And I reestablished our donation program with Project Cure, which is a nonprofit, if you don't know about them, that they collect medical supplies and they donate them overseas. So then I went there and we volunteered there, and we realized that all their expired stuff were being thrown in the trash at Project Cure because they didn't have the capabilities. I guess with customs right now, they could not get expired supplies overseas. So then I reached out to nursing schools and I said, can you guys use these expired supplies? And I found out that they can. We go through just lab tubes. They have a date on them. So if Joint Commissions come around, you have to go around and check all your lab tubes. So most of them were going thrown in the trash. But I realized the nursing schools pay 75 cents for the same lab tubes to use in their health simulation. So we started this program, and we're donating to our VOTEC high schools and our local community colleges. And it's deferring the waste, and it's really helping to reduce the cost of educating the next generation of health professionals.
Because you don't have to throw them out.
You have to throw them out.
If you're using them to train as an educational tool.
Yeah, and then we're also at the same time, all the supplies we're taking down, we're inventorying them. So to figure out what's expired and what's not expired, but inventorying them also makes the hospital leadership really understand and pay attention to what is the waste. And so then we can say we donated $15,000 worth of supplies the other day to Project Cure. So then they, as a nonprofit, can then promote that as part of their community benefit, and it makes them pay attention. And also, we now understand where our waste is. Somebody brought down cardiac caths. They're $300 per piece. They were all expired, so they can't use them. Those normally would just be thrown in the trash. But now we can say, oh, that was $13,000 worth of supplies that somebody came down. We have to do a better job of going through and making sure that those cath wires don't expire before we use them, because that's just waste, financial waste, and then physical waste as well.
And why is a piece of plastic tubing expire in the first place?
Oh, yeah.
I mean, I don't mean 40 years, but I mean, is this just part of the...
Well, firstly, just backing up a bit. So firstly, I really admire all that you've done. I will say that, as you've learned, recycling has very low environmental benefit and actually may even cause harm, as recycling processing may actually be spewing microplastics and nanoplastics through the effluent waste stream, which is another challenge that we have. But recycling also requires such complex systems to be able to do so safely in a clinical environment. In the OR, we have 12 different waste streams at my own institution. So trying to figure out where you're going to put that piece of plastic distracts you from other things that you need to do to keep patients safe and be able to continue to re-educate. So recycling is such a, while it may be something visible that people care about, detracts, takes so much energy, attention from moving upstream and addressing problems, which is generating the waste to begin with. So I think we need to address many stakeholders and really, so there's the problem of expiration is one of the issues, and we'll come back to that in a second, but I just want to say, we also are very wasteful in our clinical practices. We have the benefit of being a very wealthy society. We've, until the pandemic, unless you've done a medical mission in a low resource setting, you have no sense of how wealthy we are in our healthcare system now. So it's like a candy store. You just go and pull whatever supplies you want and without any consideration to preventing waste. And the pandemic, where we started to see patients dying in New York City because we were running out of supplies. In New Haven, we were just a couple weeks behind them in the surge, and we had similar fears that we were going to experience this. Only then did people start paying attention to the fact, well, maybe I don't need to be wasting and using all those things. So part of it is the cultural mindset, and I will tell you that after our supply chain shortages went away, we've gone back to the same wasteful issues. So as clinicians, we need to really address our behavior around waste generation to begin with, so moving upstream. In terms of the expiration dates, this is a huge problem because it's not, to the best of my knowledge, and perhaps Jeremy has uncovered this in his studies, not evidence-based, and this is something that has to come through the FDA and through the CDC. There needs to be an interagency working group to sort out issues around things like expiration dates, because part of what industry benefits from is the consumerism. So the more we buy, the more we have to throw away. So manufacturing more and more disposables, making it impossible to taking reusables off the market is another strategy that industry does to drive disposability and consumerism. And the other thing that gets manipulated is expiration dates. And this really came home during the pandemic again. Patients were dying because we were running out of supplies, and so when expired medications, expired devices were found, we had to go through testing to make sure that they were safe to use, which caused a delay. And by and large, we found, particularly the government, the federal health systems found warehouses of supplies that were still good and usable, but had to go through testing. And this can move upstream. The FDA can require. Industry should prove what the end expiration date is, not just randomly, pick one and say we're good until that point.
So, one of the things that when we were talking the other day, Deanna, you were talking about, until we have a different supply chain, which is not going to be tomorrow, you were talking about even things like inventorying and keeping better track of things, let you know, oh, we're throwing all these things out because we order too many of them. So part of it is just sort of smarter management of the disposables until we get to reusables, right? I don't know if you can quantify, but there is stuff sitting on shelves because somebody ordered too much because of the complicated contracting and purchasing world that Jodi described. How successful you've been in changing those practices? Are they ordering less of the stuff that you end up throwing out? Or you don't know yet, or you don't have the data?
We're just at the meetings with our supply, the key players in supply, and talking to them. My first meeting with them was just telling them about how harmful styrofoam was, and actually presenting what's going on with climate and health. That's what I had to start with, and then I had to present how harmful styrofoam was. The next meeting is about maximizing our medical device recycling programs, because there's a lot of confusion which programs do we participate in. And my job is to communicate to the caregivers, but when the people who are organizing them, we need to get a little bit more organized with which vendors we're using to recycle, and then maximize our materials with recycling that. But with supplies, where I work, it's a women's health emergency department, we have a medical supply for a vaginal speculum kit. And in it, there's cotton balls, laps, a towel, and a spec, but most of the time we just use the spec. So I conducted an audit. It's a metal speculum. That's the only place we have metal speculum still. I conducted an audit of how many times we use the supplies in there. And then I found out that like cotton balls are like 65 cents in there. And we've been like throwing away 5 of them all the time. I've been trying to collect them and put them in my medical supply donation bin, but mostly everybody else is throwing them away. But the change that to get people to agree on what goes into that pack has been very difficult.
So that's what sort of the one, before we talk about, I want to talk about what is it going to take to create a new industry and you know, what is that going to look like and what can the government do, what do you as the consumers of these things do. But before we get there, I want to sort of talk a little bit about the culture of change, because there are people like you, or all of you, who are looking for how to, you know, you're doing it in like a really granular way of like looking how many cotton balls and how many of this that is getting exposed and how much piping. I mean, you're looking at it in you know, really practical, what can I do with the resources I have? Jodi, you helped, I mean, Yale was 11 years ago, you said, changed the anesthetic gases. That was really early, the first you said, right? Mm-hmm. How much resistance? I mean, when you tell a colleague, besides the bureaucracy and the ordering people and the contractors who do things a certain way and don't necessarily want to change, how easy is it to get your fellow physicians to do things differently than the way they are used to doing things? And we know partly from all the research on overuse and overtreatment that how you were trained and how you start your medical practice, it's really hard to get people to change, even if intellectually they understand that not everything is necessary, they're still doing it. Mm-hmm. So take that overtreatment into overstuff. You know, when you go to a colleague and say, this is just as good for our patients and way better for our planet, do they say, oh, great, sign me up? Or are they saying, that's not how I do things?
Well, let's face it, change management is really hard, and you really have to really come from the perspective of the stakeholders. So, for example, if a non-clinician tries telling anesthesiologists to get rid of destorane, that's not going to go over well. If a non-anesthesiologist who's a physician tries to tell anesthesiologists to get rid of destorane, that also is not going to go over well. So I think you really need to understand why choices are made. In the case of that drug, it has different characteristics than other drugs. In certain circumstances, patients can wake up more quickly. But understanding that why those decisions are made to begin with, and then presenting the facts, because every one of us in the healthcare sector cares about health outcomes. That's why we're all here. That's why we come together. And so if one can present the facts about why one particular device or drug or way of doing things is desirable from the clinical standpoint, and then try and propose what's called clinical equipoise, that you do have different ways of doing things with similar outcomes, of being sensitive to the reasons why one chooses one way or another, and then present the facts. And it also helps to say, and other health systems, other countries are doing this as well. Then, you know, then there's the competitive nature that, you know, we don't want to be laggards. We want to be ahead on leadership. That said, also need to consider who the stakeholders are. So in the case of organizational leadership, they need to understand things like what's better for the bottom line, what's better for patient safety. Yes, public health is an extension of patient safety, but it's not the most immediate thing of the healthcare leaders. Also understanding what's coming around in terms of regulatory risks. Well, right now, these measures are voluntary. Both the Joint Commission and CMS have voluntary environmental standards on board that, you know, is a harbinger of requirements. So there's a risk of not figuring out how to get on board now. And then overall, things like worker attraction and retention, healthcare leaders really care about those things. There are plenty of studies that show the present generation cares about this when making decisions on where to work and where to stay and where to study. And so presenting this information to healthcare organizational leaders is also a way to help engage them and get them on board.
Jeremy, do you want to?
Oh, sure. I mean, I agree with all of this. I think value alignment, pragmatics, and getting to equipoise is crucial because, no healthcare provider is going to accept a single bad outcome done in the name of an a seemingly abstract goal of sustainability. And so getting to equipoise helps to sideline that. And I think it helps to get around three principal areas of resistance. And one is the scene of an opposition between sustainability and safety. The second is an opposition between sustainability. They should just
talk to Jodi, because she's really good at saying no, right?
Yeah, but the second is efficacy, sustainability and efficacy. What if and the third is efficiency or access, right? If sustainability is even fractionally more expensive, then that can be equated with restricting the pool of people who get access to healthcare, right? And these are very common forms of opposition we find. This is all well and good to be interested in sustainability, but if it takes away from these core goals of healthcare, then it won't work. And I think what we need to do is see behind them. These are false dichotomies, right? So yes, in the case of the disposable syringe, we can point to a lot of data that suggests that moving to disposable syringes has actually done incredible things from a safety perspective, right? But in terms of drapes, there's no reliable body of data, right? So these trade-offs here and there make sense, but they're not absolute dichotomies. And I think there's a way of disarming each of them and then actually performing in alignment on this fundamental value of wanting healthcare to actually improve the health of all of our patients in the communities that we work within. And so many healthcare providers are experiencing exactly the distress that Deanna started us off with, and they want to actually get towards that alignment. So we can help them pass the other apparent divides between sustainability and fundamental values of healthcare. I think we actually produce change.
And I think, like we talked with Secretary Becerra, that, they can't mandate, right? I mean, it's hard. You all know where we are historically, right? And even before now, it's always hard to mandate. Industry doesn't like being told what to do. They sue every time you propose a reg. The whole process is really cumbersome, and you often don't end up where you want to end up between what Congress can do and what the courts can do. And yet, the fact that there is this investment by HHS, right? I mean, there is an office. It's not doing everything that any of you would do in the perfect world. I mean, there's a lot. They're just starting, and it's limited. They're not funded. They're patching things together. But it does. I mean, having HHS, having the government officially say, we have an office that's dedicated to this, and then putting money into the IRA, which is not, it really wasn't about inflation. I mean, a huge amount of it really was about climate. I mean, that has to sort of empower, it opens the world that you're all working in to, that it does matter in some way, and that it helps create some momentum. I mean, can one of you or all of you address, like, the Joint Commission it also seems to be, I mean, it's outside of government, it's not partisan. How important is it to a health system to have that certification? Is that something that you can go to the leadership and say, the Joint Commission has this new, sustainability certificate. I want to be working, and I want us to have one work with me. Is that a tool for you, or?
The Joint Commission definitely drives so much unnecessary practice. Like, for example, I'd go in my room and to do a prenatal visit. All of a sudden, there's a plastic sandwich bag around the Doppler machine. I'm like, what's going on with this? Why do we have this in a box? And they're like, oh, we need to prove that it's clean. I'm like, well, you just clean it because that's your job, and you put it back. Why do we need a plastic bag, a Ziploc on top of that? So I think
there's a little bit of heal thyself.
Right, but it's all because to make Joint Commission happy and to show them that we're doing the right things. All of a sudden, the ultrasound machines are coming around with large plastic garbage bags to be wheeled in the room to prove that it's been sanitized in between rooms. So I'm like, why don't we just sanitize it and not have to put the plastic bag on it? Why don't we just say, we know we're doing our job because that's what we do? And so I think having Joint Commission, to have it being a mandatory option for the sustainability part, would be much more effective. And can I just say something about the change agent? So you guys are all talking about the amazing things that are happening from the top down to have the change happen. From the bottom up, I'm trying to engage caregivers and to really communicate to them that they need to care about this. Climate change is such a distant problem. So the nurses that are coming in, the younger ones that are dealing with their young families and making sure that their children are good, or their adolescents are dealing with the mental stress, and then the older nurses are caring about, taking care of their parents. Like, they're really not that engaged, right? In the Pew Research for this election, climate change and protecting the environment is 14th on the list of concern. So these caregivers, I'm trying to engage them to say, like, this is really important. So that's why I do all of my my presentations. Like, if I can have 5 minutes in a nursing meeting, I will present something about how climate and health are connected. And then I pull on them. I'm like, hey, Lauren, you just had that baby. Like, we really should care about him. So we're going to advocate for reusable pillows today because we care about Chase's future. So I drew that personal narrative because I got to engage, and I have to engage all these caregivers so that we can meet in the middle, so that the climate conversation at the hospital is so loud that hospital leadership knows, like, hey, the people that are delivering the care, they care about how we're delivering, so we are going to follow those Joint Commission standards. So it works from both ends.
Well, quick, before I go to Jodi, I have a quick question for you.
Sure.
Are you doing everything you were doing clinically on top of all the climate work, or have they changed your job and given you time to do your climate work?
I do it all on top. So I work 2 12-hour shifts in my women's health emergency department. I do everything sustainable on top of it.
And I should point out that Jodi, in addition to coming down from Yale, which is by train, so flying is not so good for the environment, is going back and doing an overnight shift tonight. So she's also another kind
I have to be back on the floor by 2:30.
He just has to go back to his computer and write his book.
So just to respond, I do agree as both and. Of course, we need a groundswell from the bottom up, no doubt. If we don't have the top down to enable that, it's not going to go as far as it really needs to. So coming back to the example of reusable pillows, we still have a problem clinically of using too much stuff unnecessarily, whether it's reusable or disposable. That's a cultural issue that we really need to address. When it comes to something like the Joint Commission and having to, cover the ultrasound machines, as the example that you provided with single-use plastic, to prove sanitation, I think the Joint Commission would argue that they hold us accountable to our own policies and procedures. They don't write them. So if we have policies and procedures in place that support reusable or cleaning and have some proof of cleaning, and that our staff, when they come and do their site visits, are aware and demonstrate those procedures, they'll leave us alone. But part of this is it's become so easy to just throw things away and not have those policies for reusables that it is a barrier. And so even if you are a clinician who cares about the fact that we're using all this plastic, it is so common to hear, I can't do anything about it because the Joint Commission requires this. And we can rewrite our policies, and the Joint Commission will hold us in account to those policies.
So that ChristianaCare has made decisions. Some of that is them using the plastics as a way of showing that.
That's right. So it is just simpler to say.
So when they tell her we can't get rid of them, actually they could rewrite their policies.
Well, right, and this is exactly what happened.
So you have some new weapons now.
Well,
right?
but this is but we've got thousands of devices, so it's become incredibly burdensome. So, and this goes back to the initial example I gave with laryngoscopes, where I trained on reusable, and suddenly 10 years ago there was this wave across the country of going to single-use disposables. And when I approached my perioperative manager, why is this happening? Oh, well, the Joint Commission is requiring this. Well, that's what he told me. I don't know if that's what he believed, but when I dug in further, what I understood was there was actually a gap in the way the CDC language was around this particular device, what infection control class it was. And so industry jumped on this to start writing in their instructions for use what infection class the device was and made it a higher class device, which they're not actually the experts, epidemiologists, hospital infection prevention control. We deem what the infection risk classification is, not industry, but because industry started putting this on their instructions, the CDC deferred to industry, then the Joint Commission said, well, you need to follow your instructions for use. So this followed through, this gap exposed to me a regulatory loophole. And so it wasn't coming from the Joint Commission. It was actually coming from industry.
So let's talk about what a greener supply chain would look like. And since it's hypothetical, it doesn't really exist. We don't know yet. Jeremy may have some insights historically, like they made us switch to disposables. how are they going to make us switch to, I mean, it's in somebody's economic interest, right? So right now, it's in the supply chain, makes money through disposables and throwing stuff out, single-use plastics. When I started thinking about this and writing about this, I mean, the supply chain is, for those of you who speak climate, it's scope 3. There are 3 levels. The supply chain is third and hardest. It's pretty easy to compost. It's a lot easier to, it's a lot harder to reinvent medical devices. And then to market them and get people to accept them and all the things we're talking about. So first, I thought it would be creating a critical mass of, and maybe it is, there's enough Yales and Hopkinses and ChristianaCares who are gonna demand, it'll be a demand-driven, that the consumer, the hospital, the health system is going to demand, but that they change, which is happening too slowly. And then I began thinking, well, maybe it'll actually, if you were looking to be, where is there going to be money a few years from now, if you're thinking I want to do a startup in healthcare, maybe that's where it's going to change. VC and startups thinking there's going to be a demand for green stuff and I'm going to get there first. When I started researching this, there are a few companies that are doing things like biodegradable surgical trays and companies that are capturing the anesthetic, the waste of the anesthetic gases, but there are not a lot of them. I mean, it's not, and some of them are not brand new. It's not, some of them are around for 10 or 15 years already, but they're still isolated. So to the extent that, how do we reinvent this massive supply chain? Is it demand? Are you going to have enough people like you to, and HHS is trying to encourage that. I mean, that's part of their strategy, is to create the demand. They're working also with the NHS in England to try to also see if they can, 2 countries or 2 systems, create more demand. Or is it going to be the equivalent of the Silicon Valley chip makers? You're going to be the Silicon Valley, plastic tube makers. I mean, do we have any signs of, how this transformation is going to come?
Yeah, so firstly, there's already a lot of consumer pressure outside of healthcare and consumer pressure within healthcare for products to be greener. So there absolutely is a market, without even getting to the examples that you gave, which actually are really not green solutions. But what it does bring us to is this problem of greenwashing. Just because a company says a product is greener doesn't necessarily mean that it is. And so what's happening in NHS England, and also is being modeled throughout the EU is really quite a very important step. What the NHS England is doing is using, it's the largest national health system in the world, 65 million members. They are using their procurement power to require industry, any company that they do business with, if they want contracts with the NHS. Firstly, they need to do ESG reporting through the Carbon Disclosure Project, which requires them to measure their emissions in a standard way, to make that transparent, it's verifiable, and to have a plan in place and to measure progress drawing down those emissions within the Intergovernmental Panel on Climate Change scientific recommendations that we need to have our emissions by 2030 and get to net zero by 2050. So requiring companies that they do business with to do that reporting and to draw down their emissions and to have it be verifiable and transparent is a very important lever of using purchasing power. And so that's what HHS is now committed to for the federal health systems, and what our large GPOs in this country can also use their power to do the same. That said, 2 things. Firstly, even if we had complete clean energy right now, we still have other types of pollutants and other types of issues. So, I know we're talking a lot about climate change. It is a bit narrow thinking. But beyond that, we need to understand at the level of the product, what are the emissions embodied within a particular product? And so there's movement now with the British Standards Institute and the International Standards Organization to create reporting standards at the level of the product, which is something we need to both avoid greenwashing, create competition in the marketplace, and to be able to allow us to also do accounting at the level of the healthcare organization, at the level of the provider. How are we doing for different types of procedures? How are we doing as different types of clinicians? How is our organization comparing to another? We need the information at the level of the product.
But if Britain is developing some of this data, because they have the ability, because they're the national health system and then their government structures allow them to do what is not currently possible in this country in terms of the mandate.
Well, it's going to absolutely help drive the marketplace.
Right, because that's transferable, right?
Well, right. Well, because most of these products are they're global, international organizations, companies, and so, if there are standards in Europe, then it's certainly going to help influence what's happening in the United States. And so, even though right now what we're doing is voluntary, we still need to understand, model, and promote what's happening.
So that could be shifting from the demand side, the demand being in Europe. That demand side is creating criteria that the market is going to have to respond to, and then we can benefit without the mandates.
That is correct. And also when it's becoming the right thing to do for healthcare organizations that provide care to be more sustainable, we should be leading this effort, not be laggards. And even if it is not mandated, we need to really get the word out there that this is a responsible thing to do. It's, it reminds me of the whole tobacco story, where clinicians would smoke at the bedside, healthcare organizations would do their investments in tobacco. None of that is acceptable now, and the same thing has to be true in terms of environmental sustainability.
Yeah, and I think there's this real triangle that you're pointing out between where industry is, where hospitals and health systems as purchasers are, right? And then where the regulatory framework is. And that if we assume it as a static relationship, then we actually sort of give up and cede to the economic bases that fuel increased obsolescence that all three of us have been describing. And yet if you look at industry itself, right? Industry itself back in the 40s, responded to a very different ecosystem in which reusability was a virtue, right? For hospital economics and for actually precision tools. Like if you take a company like Becton Dickinson, which I'm fascinated by because Becton Dickinson in the 40s and 50s is pioneering new modes of sterilization, new cleaner technologies of sterilization. In the 60s, it is part of what happens wholesale in medical device manufacturing. If shifting to plastics, the Plastipack syringe becomes sort of the most visible plastic syringe in the world. And yet, that shift isn't simply because Becton Dickinson has a strategic plan in this space. It's also reflecting what is happening by the market of purchasers as the hospital economy begins to realize that a labor problem of sterilizing its own stuff can be turned into a supply chain problem. But then if you take where we are in 2024, I see that Becton Dickinson just signed the HHS pledge just this year. Actually thinking about what a Becton Dickinson that is invested in valorizing sustainability as a set of design features. Now the risk of greenwashing is always there, and I think I'm so glad that Jodi brought this to the fore. But in order for this to work, there needs to be a form of governance that holds industry pledges in this area accountable as well. So I think what we need to do in a discussion like this today is to remind all of us that all of these things are the results of conscious human decisions, right? And that no one of these pieces, even though we become kind of accustomed to seeing things in our clinics, right, need to be the way that they are, right, or are static. This triangle is very malleable. So I think this is a virtuous, how do you shift it from the vicious cycle it's become, ecologically speaking, into a virtuous cycle? And I actually think, I think NHS Scotland is another interesting place to look, right? Because NHS Scotland, as I understand it, wants to be the first healthcare system to reach net zero by 2040. And I know one of the techniques, they have a plastics reclamation plant, and I saw a presentation in which one innovation towards greater sustainability was to shift from the plastic kidney basin, these omnipresent things in hospitals and clinics, to a metal kidney basin that could be reused.
There's also a biodegradable one.
Yeah, and a biodegradable one. And the interesting thing is but both of these point towards different kinds of possible solutions once we place sustainability as a virtue in the engineering of medical devices, which it simply hasn't been. Right, so opening up that space, either going back and rediscovering that practice of 1960, a metal kidney basin, that works really well, let's get back there. Or, hey, we actually have new techniques. If we study this with a purposeful group of material science engineers, we can find new solutions and actually create a financially successful and ecologically sustainable
The fact that the VA and the Indian Health Service and other federal, those are the VA being the biggest, the federal hospitals do have to meet climate reduction goals. Are they big enough? Does that help tilt the market in a healthier way in this country? Or I don't know what the timetable is. I don't know how long how fast they have to do that. But is that something that spills from the government hospitals to everybody else, or we don't know?
Well, first of all, let's just say any commitment coming out of HHS really means a lot. Okay, so the fact that the Department of Health and Human Services says this is important is a means to help shift culture, raise awareness around this. The federal health systems, unfortunately, only cover about 4% of our population. So in and of itself, it's not enough. However, and this would require legislature, once you start tying sustainability to CMS, Centers for Medicare and Medicaid Payment, then you're going to get a large chunk of this country, and then we're going to see the momentum.
But they're not. I mean, they're still, like the rule they proposed the other day was it's new and it's innovative and it would make a difference, but it's a subset of providers, and it was mostly, what they proposed was mostly data collection. So it's still.
I mean, I think even though it's small, I think it can be very useful as a site for modeling viability, right? We've seen this with things like pharmaceutical pricing, right? Where the ability of federal health payers to actually achieve forms of change that are thought impossible in the healthcare system in general also, occupies a really important site in U.S. healthcare policy.
And we need to wrap up in a couple of minutes, but go ahead.
I was just saying the bottom-up approach would be, when I go into the supply closet, there's no prices on anything. Healthcare providers, nurses, they don't know how much things cost. So on that bin, then that has maternity belts to hold our monitors. If you just had the price next to it, kind of just like the calorie count of food and say $8, all of a sudden, when you send that patient walk in, she comes in, she gets monitored, not in labor, go walk for 2 hours. So let the patient walk for 2 hours. But if the nurse knows it's $8, all of a sudden those belts that she's going to take off and normally would throw in the trash, and then the patient would come back 2 hours later and get a new set of belts, all of a sudden she's probably going to pass those belts to the patient and be like, hold on to these while you walk. Throw them in your purse, come back, we'll hook you back up. Because there's awareness of how much things cost. So it wouldn't actually have to be anything with regulation, but just more transparency to let caregivers, nurses, everybody know how much the price of delivering healthcare costs.
So like menu, like calorie counts, calories like your pizza on your maternity
patients
belt,
don't even have to see it. It would just be in the bins that already have the labels that show the contents of the bin. Just have to smack the price tag on there and watch how all of a sudden our staff starts to use resources so much more wisely.
And what do you see happening? I mean, what do you want to sort of, your closing message, like what do you want to let people know about where we are and where we need to go?
So my closing message in general is that something I've said as a through line is that every item that we have and we take for granted in the clinical world around us has a history behind it that's a result of human values and human decisions that may not measure up in the present day the way they did when that was made. If I have a moment for one other closing issue, though, I want to pick up on a strand that Secretary Becerra mentioned right at the very beginning, which is that of environmental justice. And so,
which is something he clearly cares about.
Yeah, and it's important to realize that we may all not benefit from the disposability of our healthcare system that has been valorized for so long, but we don't all suffer equally the costs of that disposability. I think just one point to bring home that point, one local point. I think all of us need to think of our localities and who is it that actually pays the price from an environmental justice perspective on healthcare excesses. Well, there's our patients, right? But then there's also neighborhoods. So, I would highlight the name of the Curtis Bay Energy Corporation, right, which has been renamed, but until last fall was the largest private medical incinerator in North America, right? And last fall was the subject of the largest single environmental crime ever prosecuted by the state of Maryland. It's because it was burning its medical waste. The medical waste it received, only a third of that medical waste came from Baltimore or even in the state of Maryland. 2/3 of it was being imported actually from out of the country as well. And that plume of its waste, of its smoke, was actually floating over the neighborhood called Curtis Bay. And Curtis Bay is a neighborhood, some of you may know, has the highest rates of asthma and pulmonary disease in the city of Baltimore and by many standards in the United States. And so how do we understand that these localized costs don't even become visible until we actually make concerted efforts through environmental science, through community partnerships. Many of this are made possible by forms of research granting through Department of Health and Human Service, others with partnership with, say, the state of Maryland and MDE and bringing a lawsuit forward, but a lot of which happening by partnerships with local community activists who are trying to bring to light the local cost of these care. So, we found, it was just announced actually, there was a city hall hearing in Baltimore in March 20th, in which hospital systems were held accountable for what they're going to do in the face of the local cost of this waste. And Hopkins, I'm very proud to say, has made a very careful analysis and study and is diverting its waste away, which will no longer be burned in this facility or burned at all. But this is just one local example. And I mean to say this not to say, here's a good thing Hopkins did, or here's an absolute terrible thing that has been happening in the city of Baltimore, but to suggest that this is probably true in all of our localities, right? What are the local costs? How are they borne unevenly? How do we partner effectively with those communities that are the most affected by medical waste and bring it to light?
Jodi, I don't know if you want to use your Yale hat or your National Academies hat, but because you are working on this on a national scale, sort of what, and I realized I was so interested in what you have to say, I totally forgot to ask the audience, but someone could grab you on the, if Dan has a question, is Dan, yeah. Do you have a question? Okay.
Well, I just wanted to say that really there's a lot of awareness that's coming out of the pandemic that I think everyone in the country and the world can relate to, and that is resources are limited. Like, we have very little awareness being in a rich nation until we were challenged in this way. And so when we think about climate-related disasters, which are, what is it, $14 billion storm-related damage last year alone, not including healthcare needs that stemmed out of that. When hospitals and health systems are locally affected, those populations are displaced to nearby health systems. The people in those communities, even though they weren't directly affected by weather-related events, are affected by displaced populations. And when you start dragging on the supply chain and the human resources to address those needs, it starts pulling resources throughout the network, throughout the United States and globally. And so it really requires us to think beyond our localities about how we really are all connected in this regard. And just a message would be like, this issue is not going away. It's only getting bigger. We have to be educated. We have to figure out solutions. We have the system that we created. We need to recreate our system, and we need to do it now.
Okay. Do you want to do a few questions? And I also want to, like, Jodi is going to have to get a train at some point, so if she needs to
we'll try to end this in a couple minutes. Well, I just want to say that was just an absolutely phenomenal panel. Thank you so much. But I wanted to give voice for some of the research that's happening here, and Jeremy wanted to share and might have a remark.
Yeah, wonderful. And I agree with Dan. Absolutely phenomenal panel. Jeremy Ballrick, Associate Research Professor at Johns Hopkins Bloomberg School of Public Health. I work with Jeremy Greene on a number of drug pricing issues. And there's one area where both drug pricing and climate change kind of intersect, and it's the inhaler market. So this year, Medicare beneficiaries are benefiting from generic Symbicort. Symbicort, which is a pressurized inhaler, uses what's called a HFA propellant. Really, really poor greenhouse gas profile. A single Symbicort inhaler is about 36 kilograms equivalent of carbon dioxide. AstraZeneca, GSK, they're all developing new, better propellants. So the question is, if tomorrow a new green Symbicort came onto the market with this branded drug premium, how do we balance patients' affordability with climate change, sustainability, and those different domains? Thank you.
Yeah, so Jeremy, that's such a fantastic question. I would like to open up the rest of the panel, but on some level, this is the great irony of HFA is that it was the result of a prior ecological damage that was being done by inhalers, which was the ozone hole, right? So the Montreal protocols. And the way that we dealt with that problem was that we took generic albuterol off the market, and we put the cost of it on the back of people living with asthma, right? Which we know is a disease that has many correlates with indices of poverty. And so the irony of having the burden for our collective environmental benefit on those patients who are already suffering one disease and oftentimes suffering economically as well, I think the short answer I would give is that we have to have different ways of not passing that burden directly on to patients, right? The question of whether we need to incentivize innovation on that level by actually rewarding it with the increased impetus of a brand is the structural issue I'd really like to get behind that. But I would say on both of those levels.
Firstly, just a minor clarification. I don't think that there is a green alternative or a green medicine. I mean, if we're going to talk about green, social prescribing, things like prescribing that patients connect more with members of their community, spend more time in green spaces, lifestyle approaches like dietary modification and movement. Those are things that I would call green medicine. I don't think there's a green inhaler or a green anesthetic or green surgery. I just want to dispel that there is no, it's what is least polluting that we're talking about. But you raise an important point, and this also holds true with other inhalers on the marketplace right now, that our government and our government-sponsored insurance and our private insurers need to make the cost of making environmentally preferable choices parable. I don't know how to do that, but that is something that needs to happen.
Well, I have two closing things I want to say. One is I want to thank Dan and my colleagues at HBHI who actually all really got invested in this topic and began to really see how complicated, interesting, and supremely important it is, and that's why we ended up with this event. The second, just an anecdote about greenwashing, or maybe greenwashing. A relative of mine gets medicine that comes with cold packs, it's refrigerated. And it used to be that they were, you had to just throw them out. And then the first innovation was, oh no, you can clip it, pour it down your drain, and then recycle the bag. This time we got one and it's a fertilizer. So if, like the actual stuff, they say, mix with water and pour on your plants. So if my azaleas thrive, we know, because I did it yesterday, we know that this is an environmental piece of progress. And if my azaleas die, that is literally the most, that is greenwashing. Thank everybody who's here. Tell your friends about that it is going to be shown on C-SPAN again, or I don't know how much they went live today, but this, and we'll be sharing it through social media, as will Yale. I hope you do too. And thank you for showing up. And this was, I loved this conversation. I learned a lot from you. Thank you all for coming. Thank you too for traveling. And closing words. And
just to thank Joanne Kennan, who, thank you. It was her vision that brought the secretary here, that brought this panel here, this phenomenal panel here. And I just can tell from just the content here that we're all going to go back thinking differently. And that's really the first step here. So thank you, Joanne. Thank you to the panel. And thank you for all for being here. And happy Earth Day, everybody.